We'll try to provide a concise summary of the interventional cardiology news which were presented at the ESC this year. This is my disclosure. Moving directly into the trials, the first important data were presented on dual antiplatelet therapy duration after drug-eluting stent implantation. So it was the OptiDual trial presented by a French group. Basically, patients which were stable after 12 months following implantation of a drug-eluting stent were randomized to aspirin alone versus aspirin plus clopidogrel and followed for 3 additional years and trying to see whether there were any benefits, despite the fact that the trials had been designed to include almost 2,000 patients. There was some issue with enrollment, so the trial was stopped somewhat early on in terms of sample size. Nonetheless, the power reached was acceptable, and the results were more or less non-significant in the sense that there was a trend in favor of combination therapy with aspirin and clopidogrel for more than 12 months in comparison to aspirin alone, with a lower rate, 5.8% composite endpoint rate versus 7.5, but this was not statistically significant. Major bleeding in alone was not increased either, so there was, if you will, a trend towards some benefit, which probably needs to be taken into the broader perspective or the several trials conducting on this topic. The other important trial which was presented was the third phase from the MATRIX trial, which was a kind of complex but a very important trial in acute coronary syndromes, which randomized patients first to radial access versus femoral access, and then to bivalirudin therapy versus heparin therapy, and then among patients randomized to bivalirudin therapy to simply infusion during the procedure versus infusion prolonged for at least 4 hours after the procedure. And this to understand whether we could somewhat address the suboptimal antithrombotic effect of bivalirudin with a prolonged infusion. And the data suggested that there is no need for a prolonged infusion of bivalirudin when performing percutaneous coronary intervention in patients with acute coronary syndromes. Actually, there was a trend, again, towards more benefit with an infusion, but a very tiny trend. So given the size of the trial, there is no clear signal that we should continue bivalirudin after the procedure had been completed successfully. Another very important trial moving from drugs to devices is the Absorb STEMI TROFI 2 trial, which is not a very large trial, almost 200 patients, but a very important trial in terms of mechanisms and pathophysiologic insights on this new device, which are bioresorbable vascular scaffolds, so Absorb. Basically, these were patients with STEMI, so patients who we would not consider strictly as candidate to absorb. They were randomized after thrombectomy and predilation to implantation of Absorb versus Xience, and then they underwent 6 months later OCT, or the equivalent, which is OFDI, basically is similar, very similar to OCT, and the endpoint was exactly an OCT OFDI outcome, which is healing score. And we can focus on healing score if we want. Basically, healing score is taking into account a number of potentially important signals at invasive imaging, which include the presence of intraluminal defects, the presence of malapposed and uncovered struts or scaffolds, uncovered struts or scaffolds, and malapposed ones. So you can see that whenever you have this kind of images, you of course feel the patient might be at higher risk and the healing might be less optimal than what we would like to have. And the results were clearly towards non-inferiority of absorb and actually a trend toward a better healing with the absorb and almost reaching superiority in terms of p-value. Weight loss was though somewhat higher with absorb, so 0.20 with absorb versus 0.08, which was significant. Focusing again on absorb, we have also recent data presented in ESC from Japan, so a different type of patient population, 400 patients. This was kind of a semi-all-comer trial performed for regulatory approval. Patients were randomized to Xience versus absorb, and the primary endpoint was a clinically patient-oriented one. And the design was basically a non-inferiority design aiming at showing that the two treatments are similar in terms of safety and efficacy. And the results were actually very in favor of this hypothesis, with a 4.2% TLF, so target lesion failure with absorb, versus 3.8% with a metallic stent, and similar results in this case also for weight loss, so showing clearly that in this kind of patient population with this kind of technique of implantation, the absorb can achieve similar results to those provided by the best or one of the best metallic stents currently available. We have also received data from pooled analysis, in this case a pooled analysis by Dr. Piccolo from Bern in Switzerland, in which 4 randomized trials comparing new generation drug-eluting stents versus early generation drug-eluting stents were combined, focusing on 2-year follow-up data, and a number of endpoints were appraised. First of all, the composite of cardiac death, myocardial infarction, and target lesion revascularization. The analyses were not simple, crude analysis, but were adjusted for age, diabetes, renal failure, and previous MI, with a very complete follow-up rate considering the in favor of new generation drug-eluting stents, with an adjusted hazard ratio of 0.75, and you can see from the curve here the reduction in the risk of cardiac death, myocardial infarction, and target lesion revascularization. Accordingly, similar benefits, actually almost half the risk of target lesion revascularization was achieved with new drug-eluting stents, but most importantly, this data showed an hazard ratio of 0.40, highly statistically significant in favor of new drug-eluting stents in comparison to early generation drug-eluting stents for the outcome of stent thrombosis. As you can see, almost 1/3 of the risk, so striking benefits in terms of safety as well as efficacy. So something which, again, proving how new drug-eluting stents have actually changed the paradigm of drug-eluting stent safety and efficacy balance. A stratified analysis showed that the benefits of drug-eluting stents, of new drug-eluting stents, were particularly strong in complex patients. As you can see, you actually could demonstrate a reduction in cardiac death in patients with a complex syntax score, as well as a reduction in definite stent thrombosis. So these results really make the compelling case that we need to use drug-eluting stents, new generation ones, very effective and safe ones, because we can really provide meaningful benefits to patients which go beyond simply the reduction of stenosis and TLR. In this trial, Sabate from Barcelona in Spain provided very long-term follow-up data comparing Xience, so everolimus eluting stent metallic platform versus its bare metal counterpart, and showed that even after 5 years, use of Xience was associated with significant clinical benefits in terms of reduction in all-cause death, any myocardial infarction, or any revascularization. So a very conservative endpoint, very potentially penalizing endpoint for a simple device implanted in a culprit lesion. So this data as well provide very strong case, strong evidence in favor of new generation drug-eluting stents, not only in comparison to previous generation drug-eluting stents, but also in comparison to bare metal stents in very complex and potentially prothrombotic settings, such as acute MI. Moving from trials to observational data, which are very important to see whether the trial data can be translated into clinical practice. Roberts provided the insightful registry data from Canada on radial access, showing a progressive trend in moving from transfemoral to radial access, despite the fact that Canada is among the pioneer countries for radial access, and showing that despite this shift, which included, of course, high-risk patients, more complex procedure, the unadjusted crude mortality and complication rate, including transfusion, did not change significantly over time. If we also then take into account the patient features, then we can demonstrate in this registry data a strong association, independent association. We can see that fractional flow reserve is still associated with significant reductions in the risk of death, myocardial infarction, or revascularization in comparison to a simple angio-guided revascularization procedure. Some other insightful data have been provided on a novel approach to tackle adverse left ventricular remodeling, in this case, the intracoronary injection of a bioabsorbable cardiac matrix to prevent or stabilize LV remodeling after large acute myocardial infarction. And this was the preservation data, the preservation trial. Basically, the trial consisted of the injection of 4 mL of bioabsorbable cardiac matrix in the coronary artery versus saline control shortly after a primary PCI procedure. Unfortunately, the trial did not show a significant benefit in terms of clinical endpoints or remodeling endpoints. So despite the compelling basic data and the insightful hypothesis, this trial showed non-significant negative results. And moving to the conclusion, we have also interesting data on how we should manage patients with out-of-hospital cardiac arrest, showing from Japan that we can obtain a reasonably favorable neurologic outcome if we continue resuscitation up to 35-40 minutes. Conversely, after that time frame, the likelihood of getting a favorable outcome 1 month after the cardiac arrest is nil or dismal. So concluding, The four main topics with the relevant news are antithrombotic treatment, drug-eluting stents, BVS, PCI, and heart failure. And basically, we have from the OptiDual trial no clear benefit or harm in prolonging the APT after 1 year. From the Matrix trial, we have data suggesting that we can discontinue the bivalirudin infusion at the end of the PCI. From the TROFI 2 trial, we have data suggesting that there is comparable healing between BVS and ES after STEMI, that BVS and ES are similar in terms of safety and efficacy. From Absorb Japan, that Xience is superior to bare metal stent in STEMI, even long term, and that, of course, new drug-eluting stents are better than old generation ones. The FAME trial was confirmed at 5 years. Radial approach came out again winning over femoral, and unfortunately the preservation trial provided negative results, and we know that there is a reasonable 35 minutes cutoff to continue resuscitation after cardiac arrest. Thanks.